33-year-old man presents to a United States emergency department with 3 weeks of progressive bilateral leg swelling, abdominal distension, and orthopnea that worsened over 48 hours. Past medical history includes biopsy-proven minimal change disease in adolescence with complete remission, type 2 diabetes diagnosed 4 years ago, treated pulmonary coccidioidomycosis 2 years ago, and a repaired inguinal hernia. Family history. Father underwent kidney transplantation in his 50s for immunoglobulin A nephropathy. He denies nonsteroidal anti-inflammatory drug use. Social history. Vegan diet with frequent high-sodium packaged foods. Multiple sexual partners with consistent condom use. No tobacco. Occasional alcohol, up to 2 coffees daily. No pets. Allergies. Tree nuts, swelling, and seasonal allergic rhinitis, congestion. Initial emergency department vital signs: temperature 37.0 degrees Celsius, pulse 89 per minute, respirations 18 per minute, blood pressure 149 over 97 millimeters of mercury, oxygen saturation 81% on room air, improving to 95% with supplemental oxygen. Physical examination: periorbital puffiness, jugular venous distension to the angle of the mandible at 45 degrees, basilar crackles, S3, shifting dullness, 3+ pitting edema to the mid-thighs, mild non-tender gynecomastia, benign caffeolate macule on the left flank, no rash, livedo, purpura, or synovitis. Neurologic exam is normal. Initial laboratories: sodium 138 millimoles per liter, potassium 5.2 millimoles per liter, chloride 103 millimoles per liter, bicarbonate 20 millimoles per liter, blood urea nitrogen 52 milligrams per deciliter, creatinine 3.0 milligrams per deciliter. Chronic Kidney Disease Epidemiology Collaboration 2021, estimated glomerular filtration rate calculated 27.27 and rounded to 27 milliliters per minute per 1.73 square meters. Glucose 168 milligrams per deciliter, calcium 8.2 milligrams per deciliter, phosphate 5.5 milligrams per deciliter. Complete blood count: hemoglobin 11.6 grams per deciliter, platelets 230 times 10 to the power of 3 per microliter. Hepatic panel: AST 28 units per liter, ALT 25 units per liter, ALP 98 units per liter, total bilirubin 0.7 milligrams per deciliter, albumin 2.7 milligrams per deciliter. Coagulation: international normalized ratio 1.1, activated partial thromboplastin time 31 seconds. Serologies: complements normal, anti-nuclear antibody negative, anti-neutrophil cytoplasmic antibody negative, anti-phospholipase A2 receptor negative, hepatitis B surface antigen and core antibody negative, hepatitis C virus antibody negative, 4th generation human immunodeficiency virus screen negative last month. Serum and urine protein electrophoresis with immunofixation negative, serum free kappa to lambda ratio 1.15. Urinalysis: specific gravity 1.020, 3+ protein trace glucose, 0 to 2 red blood cells per high power field, no red blood cell casts. Phase contrast urine microscopy: predominantly isomorphic red blood cells without acanthocytes. Polarized microscopy: numerous oval fat bodies with Maltese cross birefringence. Quantification: spot urine albumin to creatinine ratio 1,200 milligrams per gram. 24-hour urine protein 1.6 grams per day, with repeat values 1.5 to 1.7 grams per day over the past 3 months while taking a maximally tolerated angiotensin-converting enzyme inhibitor. Electrocardiogram: normal sinus rhythm at 89 per minute without peak T waves. Portable chest radiograph: pulmonary interstitial edema with cephalization. Bedside renal ultrasound: right kidney 10.5 centimeters, left 10.7 centimeters. Increased cortical echogenicity, preserved corticomedullary differentiation, no hydronephrosis, hepatic and portal venous flow normal. Prior results in the electronic health record: hemoglobin A1C 6.8% 1 month ago, thyroid function normal, thyroid stimulating hormone 1.2 milli-international units per liter, free thyroxine 1.2 nanograms per deciliter. 2 weeks ago, abdominal fat pad fine needle aspiration, no Congo red positive material, no apple green birefringence, electron microscopy without fibrillar deposits. 5 months ago, lumbar spine magnetic resonance imaging, L5 to S1 posterior disc protrusion without canal compromise. 11 months ago, colonoscopy and sigmoidoscopy for intermittent hematochezia, grade 2 internal hemorrhoids only. 6 months ago, diagnostic mammography during evaluation of tender gynecomastia, while on spironolactone since discontinued. Benign symmetric gynecomastia, breast imaging reporting and data system 2. 2 months ago, in-lab polysomnography, mild obstructive sleep apnea, apnea-hypopnea index 8 per hour, without nocturnal hypoxemia, contemporaneous pulmonary function tests, mild restrictive pattern. 12 months ago, ultrasound-guided fine needle aspiration of a 1.2 centimeter left thyroid nodule, Bethesda 2, Epstein-Barr encoding region negative, fluorescence in situ hybridization for rearranged during transfection, papillary thyroid carcinoma rearrangement negative. 10 months ago, transthoracic echocardiogram, normal left ventricular size and ejection fraction 60% with normal right-sided pressures. Current medications: lisinopril 40 milligrams by mouth daily, furosemide 80 milligrams by mouth twice daily, amlodipine 10 milligrams by mouth daily, atorvastatin 40 milligrams by mouth nightly, loratadine 10 milligrams by mouth as needed. Metformin was discontinued last week when creatinine rose to 3.0 milligrams per deciliter. The patient is admitted to a monitored medical ward for oxygen supplementation and aggressive diuresis. After initial stabilization, which management choice regarding a native kidney biopsy, and the first disease-modifying therapy aligns best with randomized trial evidence in chronic kidney disease and contemporary U.S. label and guideline dosing thresholds, given estimated glomerular filtration rate less than 30 milliliters per minute per 1.73 square meters, persistent proteinuria greater than 1 gram per day, stable for 3 months on angiotensin-converting enzyme inhibition, a bland urine sediment without active casts, negative monoclonal and amyloid evaluations, and no systemic features. Option A: defer both kidney biopsy and sodium glucose cotransporter 2 therapy now. Continue angiotensin-converting enzyme inhibition and intensified loop diuretics alone, and reconsider starting dapagliflozin only if the estimated glomerular filtration rate improves to greater than or equal to 30 milliliters per minute per 1.73 square meters at a 3-month review, reflecting earlier label cautions and concerns about starting below 30. Option B: defer an inpatient native kidney biopsy. Once near euvolemic at the end of this admission, initiate dapagliflozin 10 milligrams by mouth once daily, SGLT2 inhibitor, at or just before discharge, with close follow-up in 1 to 2 weeks for volume status, serum creatinine, and potassium. Continue the maximally tolerated angiotensin-converting enzyme inhibitor, and arrange a semi-elective outpatient ultrasound-guided native kidney biopsy in 2 to 4 weeks only if albuminuria remains greater than 1 gram per day or new active urinary sediment or systemic features emerge. Option C: perform an inpatient ultrasound-guided percutaneous native kidney biopsy during this admission within 24 to 48 hours after stabilization with pharmacologic venous thromboembolism prophylaxis held, and begin dapagliflozin 10 milligrams daily only after histology confirms a primary glomerulopathy. Continue the angiotensin-converting enzyme inhibitor and discharge once bleeding surveillance is complete. Option D: defer an inpatient biopsy, but require an outpatient ultrasound-guided native kidney biopsy within 7 to 10 days regardless of subsequent trajectory. Start dapagliflozin 10 milligrams daily at discharge, and maintain the ACE inhibitor while planning biopsy even if albuminuria falls below 1 gram per day and sediment remains bland. The correct answer is option B: defer an inpatient native kidney biopsy. Once near euvolemic at the end of this admission, initiate dapagliflozin 10 milligrams by mouth once daily, once DLT2 inhibitor, at or just before discharge with close follow-up in 1 to 2 weeks for volume status, serum creatinine, and potassium. Continue the maximally tolerated angiotensin-converting enzyme inhibitor, and arrange a semi-elective outpatient ultrasound-guided native kidney biopsy in 2 to 4 weeks, only if albuminuria remains greater than 1 gram per day or new active urinary sediment or systemic features emerge. In a patient with estimated glomerular filtration rate 27 milliliters per minute per 1.73 square meters, persistent proteinuria around 1.5 to 1.7 grams per day despite maximized angiotensin converting enzyme inhibition, bland sediment, negative monoclonal and amyloid evaluations, and no systemic features. The evidence-based, label-concordant move is to start dapagliflozin 10 milligrams daily once near euvolemic and to defer inpatient biopsy. Randomized trial data demonstrate kidney protective benefits of dapagliflozin down to estimated glomerular filtration rate 25 milliliters per minute per 1.73 square meters, including in stage 4 chronic kidney disease subgroups, without requiring histologic confirmation before initiation. Initiating sodium glucose cotransporter 2 therapy at discharge with close 1 to 2 week follow-up, volume status, creatinine, potassium, leverages the early hemodynamic effects and long-term renal protection. Continuing the ACE inhibitor is appropriate if potassium and creatinine permit. Biopsy can be arranged as a semi-elective outpatient study in 2 to 4 weeks if albuminuria remains greater than 1 gram per day or new active urine sediment or systemic clues appear, preserving diagnostic flexibility without delaying a proven disease-modifying therapy. Performing an inpatient biopsy now adds procedural risk during decompensated volume overload and would not alter the immediate decision to start a sodium glucose cotransporter 2 inhibitor at this estimated glomerular filtration rate. Mandating biopsy within a fixed 7 to 10 day window, regardless of trajectory, ignores the potential for proteinuria reduction on optimized medical therapy and misallocates procedural resources. Conversely, deferring both biopsy and sodium glucose cotransporter 2 therapy until estimated glomerular filtration rate recovers to greater than or equal to 30 reflects outdated label cautions superseded by current evidence and U.S. labeling, which permit initiation at or above estimated glomerular filtration rate 25 and continuation below that threshold. The KEED plan best integrates trial evidence, the current label, and pragmatic inpatient to outpatient transitions.